Monkeypox. What do we know so far? Virus type and mode of transmission. Monkeypox is a zoonotic disease caused by the mpox virus, primarily transmitted from animals to humans including squirrels, rats, monkeys, primates, prairie dogs, hedgehogs, pigs, and mice, but recent outbreaks have been driven by human-to-human transmission. The virus spreads through direct contact with bodily fluids, skin lesions, or respiratory droplets, with sexual transmission also playing a significant role. Diagnosis. Mpox infection can be confirmed via isolation in viral culture or by PCR for mpox virus DNA from a patient specimen. Alternatively, tests indicating the presence of orthopox virus in a patient specimen, barring patient exposure to another of the same genus, can be sufficiently diagnostic, such as visualization on electron microscopy, immunohistochemical staining for orthopox virus antigens, serum studies for anti-orthopox virus IgM, indicating recent exposure, and IgG, indicating prior exposure or vaccination. Symptoms. The incubation period for the disease is typically 7 to 14 days, with symptoms starting as fever and swollen lymph nodes before lesions appear. Lesions progress through several stages, macular, papillar, vesicular, and pustular phases, over 2 to 4 weeks, and patients are no longer infectious once all crusts have fallen off, usually around 3 to 4 weeks after symptom onset. Treatment and vaccines. Currently, there are no specific clinically proven treatments for mpox infection. As with most viral illnesses, the treatment is supportive symptom management. There are, however, prevention measures that can help prevent an outbreak. The infected individual should remain in isolation, wear a surgical mask, and keep lesions covered as much as reasonably possible until all lesion crusts have naturally fallen off and a new skin layer has formed. For severe cases, investigational use can be considered for compounds with demonstrated benefit against orthopox viruses in animal studies and severe vaccinia vaccine complications. The efficacy of brincidofovir, tecovirimat, and vaccinia immune globulin against mpox is uncertain. Tecovirimat and brincidofovir may be used together in severe cases. Post-exposure vaccination with the modified vaccinia Ankara vaccine is recommended for high-risk exposures and can prevent or reduce disease severity if given within 14 days. The vaccine is a 2-dose series with a better safety profile compared to earlier smallpox vaccines. More data is needed to assess the benefits and challenges of mpox vaccination in endemic areas. There is ongoing clinical trials and research to develop mRNA vaccine for this virus. Thank you for listening. Dr. Samad Tamo.